message from the research is that doctors, to be fully prepared, need more on-the-job experience. And obviously, in the theme of today, particularly more prescribing experience. I've also brought a few copies along of our report. If anybody is particularly interested, I'll leave those at the back of the room later today. As you can see, a very large group of researchers undertook this study. The GMC was interested to know whether medical graduates, when they leave medical school, are fully prepared to start work. And the reason they were interested is because of a piece of work done by Michael Goldacre in 2003, which suggested that only 40% of medical graduates did not feel fully prepared to start work. And also that preparedness varied depending which medical school they attended. And so they wanted to understand a little bit more about that. So we undertook a study comparing three what we thought were diverse medical schools. Newcastle, where I am from, in the northeast, a system-based traditional university. Warwick, it's graduate entry, 4-year course selecting students of sort of biological sciences, and Glasgow University, which is a problem-based curriculum. So the aim was to look at these three universities and determine, how they prepared their students and if they prepared them in a similar way, and what they were prepared for and what they were not prepared for. So it was a complex methodology, as I've already said. We collected qualitative and quantitative data. First of all, I'm going to talk about the quantitative data. We had a cohort questionnaire delivered to each cohort at medical school just before they started work, during shadowing, asking them questions about what they're prepared for, with reference to the GMC's policy document of what they were expected to do when they started work. We also looked at the assessment data that they would be completing when they started work, so particularly looking at the DOPS, looking at the procedures that they would be tested on when they started work. We also looked at prescribing assessment, which was undertaken in Newcastle and Warwick, in which they had to get 100% to pass and keep on taking until they got 100%. And we also looked at a clinical team questionnaire, so people who worked with these doctors when they left medical school and started, asking them questions about what they could and couldn't do when they started on the wards. So the findings from that quantitative data, basically, we found in all groups of the quantitative data that they're fully prepared for history taking. They could talk to patients, they could examine patients, and they were good at team working. And they were prepared for simple procedures, and that was reflected in the DOPS that they chose to be examined on quite early in their career. So when after 4 months they already decided, for example, to be examined in sort of taking blood and things like that. They were less prepared for complex procedures, and that would include catheterization, for example. And obviously, your interest, less prepared for prescribing. Interestingly enough, again, the themes that have already been discussed today, that was identified by the doctors themselves, then as F1s, but particularly identified by the pharmacists, particularly the ward pharmacists, who, as you say already, they were the people that worked with them, identified those problems. So sometimes people people who are in the team, the rest of the team, were less aware of the difficulties that these F1s had in prescribing. And there was a low pass rate on the prescribing assessment. I think it was 18% passed in Newcastle and 16% passed in Warwick. So that pass rate, very low, but don't forget they had to get 100% to pass. Moving on now to the qualitative data, we selected 20 final year students from each of the medical schools. And we interviewed them before they started work, and after 4 months, and then after 12 months. You can see we started off with 65 because we got a few extra wanting to take part, or we over-recruited at one place. So the idea there was to get their views on what they thought they were prepared for before they started work, and then find out in the early months when they actually started work how they were doing, and then get their views looking back after a year to see how they thought they were doing as a young doctor. We also interviewed undergraduate tutors, people who taught them while they're undergraduates. We also interviewed educational supervisors who supervised them when they started work, and also key managers like foundation program managers who got a sort of an overview of the foundation program. We also undertook 3 focus groups with portfolio assessors, and the purpose for that was because they were going to be looking at these portfolios and containing all their assessments, and again they may have a view of what they thought they were weak on in terms of preparedness to start work. In total, we undertook 250 qualitative interviews and focus groups. If anybody has undertaken qualitative interviews before, they will know that's a huge amount of interviewing. So the findings from the qualitative data, the areas in which they were fully prepared. Again, communication skills that recognised earlier from the quantitative data, history taking appears again, clinical practical skills appear again, and so does team working. Anatomy, I've put it as a question mark, that came out of the earlier interviews. We started with Warwick, who the students had concerns themselves about whether they were fully prepared for anatomy, and so we pursued that thread really through the other interviews and found out their concerns were really voiced through clinicians, possibly surgeons having concerns about them, but actually when they started work they knew enough to do what they needed to do, and if they needed more knowledge about anatomy then they'd look that up before they started work in surgery, for example. Areas of lack of preparedness, prescribing, top of the list. I'm going to talk a little bit more in detail about prescribing, so I'll leave that for the moment. Managing patients who are acutely ill, particularly if they were the first one to come to that patient and in the heat of the moment had to decide what to do while they're waiting for help. Working on call was a particular concern for them, particularly if they were working on call at night when there was less support available to them. Prioritising patients and managing their own time, something they'd never done before. Perhaps 6 nurses may come to them saying, I want you to see this patient or I want you to see that patient, and they didn't know which patient to see first, how to prioritise their time, how to prioritise these patients. Hospital procedures and paperwork, they had very little time in medical spent on the paperwork that they needed to complete when they were doing their tasks in the hospital. And we had quotes from people saying that if a consultant asked them for a scan, they'd write urgent on the scan, but were surprised then when it wasn't carried out urgently. They didn't understand the system they were working in. Knowledge of the NHS as well, understanding how primary care and secondary care interface, understanding how you refer to the community, the services within the community, and also legal and ethical issues, understanding what you do if something goes wrong. And things did go wrong, and sometimes young doctors had conflicting evidence from their team. Oh, put this in your report. Oh, don't write that. So they were really sort of very confused about what to do. Now, focus on prescribing. Prescribing is one of the biggest steps in practice. It's a very high-order activity. There is quite a lot of research already today. You talked a lot about the Dornan study, and the other studies, many studies already that have identified underconfidence and injuries caused from mistakes in prescribing. And Dornan, like our own study, stressed the importance of linking theory to practice, importance of learning on the job, actually prescribing for real patients that have complex systems, have lots of things wrong with them, and are already on a whole load of other drugs, rather than doing it in a classroom setting where everything is very sort of calm and meticulous, and you're not crowded in the way you're crowded in the job with so many other things going on. Prescribing, they felt underprepared when they started work. And these concerns were realised in practice, and more errors were reported in prescribing than any other area. And some of the errors were quite minor, and as I said already, the majority of errors were identified by the pharmacists working on the ward, so it reduced any impact for errors to be pushed through to the patient. A couple of quotes here. First one from a student from Glasgow in the first interview. It's just how to make the choice of which drug to choose, in which situation, and, more importantly, interactions. Another quote here from Newcastle, doctor at follow-up. You know, things like learning doses and learning drugs when you haven't got a context to put it in is really hard, and it's just names. So we identified that sometimes learning in the classroom away from the ward just didn't do it for students. Sometimes they really needed to be with the patients to understand and be interested and to be alert to what an important topic prescribing was. And these views from the clinicians that we interviewed who worked with those doctors. As I said, we interviewed 92 clinicians. There was agreement across all sites that they were underprepared for prescribing. So quote here from a Warwick educational supervisor. There is one area where they aren't prepared, and that's prescribing. The triangulating questionnaire from 80 clinicians who worked with the F1s on the wards also agreed that they were underprepared, but particularly the pharmacists. They identified the weaknesses, particularly in drug histories, calculating doses, completing drug charts, writing clear and legible prescriptions. So prescribing was the main theme in both the anticipated and experienced problems, and it was confirmed from all sets of data. Prescribing is a skill that needs to be applied and experientially learned to be fully understood. So the conclusions from the whole study really was that the things that we identified that they weren't prepared for, things like prescribing, working on call, dealing with paperwork, prioritising patients, these are all things that are best learned on the job. So instead of doing simulation or talking in classrooms or role-playing, they need to be out there on the wards, learning, but not just observing. We found that some of the students were apologising for being there. They needed to be actually actively doing, supervised doing the job. So students need to have more opportunity to have a skill base, to apply prescribing, to perhaps it could be done as in a sort of dummy prescription where somebody checks it, or it could be a real prescription that's signed by another doctor. But they need to do it in real clinical practice to be fully prepared. We looked at doctors using the MTAS score, which I didn't mention earlier, to see if ability had any impact on preparedness, and we found that that wasn't relevant. It was actually being exposed to the job before they started work which fully prepared them. There were minor differences between the medical schools. Warwick graduates were slightly more mature and seemed to be better prepared for perhaps more complex decision-making, more complex communication in particular. And Glasgow, because they're problem-based learning, they have to go and learn more themselves. They seem to be better able to ask questions and perhaps better able to direct their own learning. There was greater knowledge of role in legal and ethical issues in the NHS we thought would also be improved by being on the job more. They'd see these legal issues in practice. They'd be able to ask questions, not just to their teachers, but to other members of the team on the wards about how things were in the job. So we've sort of hypothesised about why are these junior doctors not getting the practice that they used to have years ago? Well, obviously the senior clinicians talked about the sort of demise of the locum post. In the past, they would go and work as locums, so they'd do the job before they actually finished college. Also, we've already, one of the speakers referred to that this morning, talked about the demise of the firm. Everything's very shaky now. Shift working, quick changes of staff, the European Working Time Directive. There is also the feel that perhaps patients are discharged more quickly. Everything's done more faster. Patients are actually iller than they were before. Maybe it's more risky for young doctors to have more contact with them. But also there are other students competing now for this practice. F2s who haven't had the opportunity to do certain procedures on patients, they want to do these procedures. And as do nurses who are coming in now, they are mainly learning outside in the universities rather than on the job as they used to many years ago. Also, perhaps there's a prioritisation of library learning over experiential learning, and that when they go to the wards, their focus is on learning A, B and C, whatever that is, and forget to look at, actually you can learn a lot more than A, B and C on that ward, to look around and observe and learn about the whole environment of working on the job. Now, we made some recommendations. We recommended that students should be in placements that involve the student in authentic workplace practice. So yes, it's important to observe, but towards the end of their career, before they start work as a doctor, they need to be supervised doing the work that they're going to do when they start work, so that they are fully prepared and they're supervised in that action, so there is less risk to the patient. And also we stress the importance for graduates to have a role in the team, that to stop them apologising for being there, standing against the wall, observing, that if they're given a role, then that involvement in the team becomes more authentic. prescribing, there needs to be more applied learning, they need to be out there watching other doctors prescribe, talking about it, but also doing it themselves in a complex, crowded environment, which is the real workplace practice. We also identified a need for improvements to shadowing, because we found that some doctors, they'd start the job and they'd never been on that ward before, they'd never shadowed the person that they were about to sort of, take over from because of, other complicated arrangements, and that disadvantaged that doctor. We also suggested moving exams back in time so that the last few months or weeks as a graduate could be just focused on, or the graduate could think about just preparing themselves for work without having to worry at the same time about final exams, which may be distracted from the importance of getting ready to start work. Thank you very much.